I'm Charlotte Fraser, a partner in the Contentious Trust and Estates team at Farrers, and we're here to talk about mental health and in particular capacity. Do you want to introduce yourself, James?
Yes, hi. Hello, Charlotte. Thank you for asking me to come. My name is James Warner. I'm a consultant psychiatrist specialising in older people's mental health and mental capacity, and I'm medical director of Halcyon Doctors.
And we're here really to talk about the interplay between medicine and the law when it comes to mental health and capacity, and in particular, I think some of the common pitfalls that lawyers might experience, and in fact other advisors when they're advising clients who may have mental health conditions, whether they're diagnosed or not. So as a starting point, what would you say are some of the common signs that someone may be experiencing a mental health condition?
Well, there's a vast array. I think one of the things I would say is that if someone is inconsistent or having difficulty getting the uptake or understanding what's being said, or they keep coming back and forgetting previous conversations, that's an obvious red flag. But sometimes it's a bit more subtle than that. So I would look for their appearance and behaviour. And of course, people are entitled to be dishevelled and smelly. That doesn't mean there's anything wrong. But if you've known someone and they're usually dapper, and then after a few years they're coming in and they're looking dishevelled and not well dressed, then think to yourself, is something going on there? Likewise, behaviours. People can appear perplexed or they can appear bewildered. They can become very tramlined in their thinking and very fixed. I saw a patient a few months ago whose solicitor, very astute solicitor, picked up the fact that every time it was divorce settlement and every time he was coming to a meeting, he was clutching the same piece of paper with the same division of assets on, and he was insisting that this was how it was going to be. And that alerted that solicitor.
And it's much easier, isn't it, if it's a client you've got to know well over a number of years than perhaps if it's someone you haven't known for very long.
Yes, and if it's someone you've not known very long, then you're on the back foot, obviously. What I would say in this is that people should use their intuition quite often. There's an inner voice when we meet someone saying to us, something's not quite right here. And I think that we don't listen to that inner voice enough. So despite what all I've said to you, if your intuition is that someone's struggling in terms of capacity, listen to that and perhaps act on it.
And I think perhaps one of the common pitfalls that we come across is that people just assume that mental health conditions are for the elderly and think of the obvious conditions that might entail. But actually, I think that's quite a dangerous path to go along.
Oh, it's a very dangerous path to go. Certainly when we're thinking about some of the big picture reasons for incapacity, such as dementia, then yes, you're mainly dealing with the elderly, but younger people have got significant mental health problems. In fact, particularly since COVID, the increase in mental health diagnoses among younger people has soared. And younger people can develop quite significant issues around capacity because of things like depression, because of psychosis, and very often now because of drug use. And not only the acute intoxication issues around drugs, but the chronic conditions that they lead to, like psychosis and anxiety and depression.
And it can also be perhaps some other underlying health condition which can cause temporary loss of capacity.
Well, this is a big issue for me, and one of the drums I keep banging on about is the issue of acute confusional state and delirium, and particularly if you as a professional, you're seeing someone in a hospital setting or a care home setting, then the risk of them, especially older people, the risk of them having an acute confusional state because of a physical condition such as pain, constipation, heart problems, breathing problems, infections. These can lead to profound problems with cognition and therefore mental capacity, but they're often not picked up and they're often not detected. I suppose that leads me to a question to you, Charlotte, which is that if a lawyer does have a suspicion, what next? Because I know that you're quite bound by client confidentiality. So what do you think the best next steps are?
I think it's very difficult. I think it always helps in that a lot of the meetings that we have with clients, there would be another person present. So you've almost got that sort of check and balance in place. If you've picked up on something in that conversation that doesn't feel quite right, as you said, in terms of intuition, you've at least got someone who was present in that meeting that you can run it past and say, did you pick up on that? But I think if you both have identified that there may well be an issue, the next step is, I think, to have that difficult conversation with the client. And I think it's the one that most solicitors and advisors hesitate and are very uncomfortable about having. But I think, as we've touched on in the past, in previous conversations, actually solicitors' offices are probably one of the most intimidating places in the world. And I think perhaps one of the first things that we would do is try and suggest having a meeting with that client at home or in an environment where they're more likely to feel comfortable and may well perhaps open up to you. Because I think, in my experience, sometimes clients actually know that something might not be quite right, and they've done a pretty good job at hiding it. I mean, you must see that people will go to great lengths to hide, perhaps if they know that something's happening and they're trying to deny it, and their behaviour may well be affecting how they treat other people in their lives. They really don't want anyone else to suspect it.
Well, you've brought up two very interesting points. The first is going to people's homes, because, of course, people will feel more comfortable there, less intimidated. But it can also, certainly from a clinical perspective, but also I suspect from your perspective, can give you significant clues as to what's going on and whether there are real problems. You know, is the environment safe? Is it clean? Is it well ordered? And then in terms of the breaking of news or the discussion, then I think that is definitely best done in a person's home. But it's because what's the next step? Because you're not doctors. You can't diagnose. You're not going to want to diagnose. But perhaps the next best step usually is getting someone to see their GP if you're worried about their health.
It's an open question, I think, isn't it, really? I think it's easier if you've got a client who's suddenly changed their mind about something that they felt very strongly about for many years, or where there's a big decision that doesn't feel quite right in the context of their previously held views. It's much easier to have a conversation and say, oh, I was a bit surprised. I think we just need to be a little bit careful because it goes against what you've said in the past, so we're going to have to document it very carefully. And you can sort of tease out of them what the motivation might be behind that change, and that may well be the opportunity to sort of ask, is everything okay? It doesn't seem to fit with what you thought in the past. That's easy when you've got a big decision, but when it's just a sort of run-of-the-mill daily administrative job that doesn't necessarily seem as though it's a sort of a seminal moment in their lives, but there's a nagging feeling in your mind that something's not quite right, they may well not be as willing to open up with you. But at least if you're in their home, you can also get a sense, as you say, not just of their surroundings, but their relationships with other people. Because anyone with any sort of mental health vulnerability or condition may well be susceptible to influence, whether it's undue or otherwise, or to pressure from other people to make decisions that actually don't necessarily represent what they really want.
Well, you've opened up a whole can of worms
about
undue influence, which we might come back to. I just want to come back to your issue about an individual's insight. Are their awareness, and the classical issue with people with a lot of different mental illnesses, including dementia and schizophrenia, is often they don't have overt insight, so they're not going to come to you and say, I'm ill. But on one level, usually they know there's something wrong, and once you've got the door slightly ajar, you can push the door gently and get individuals to open up and to acknowledge. You can, and in some ways you can use the law to your advantage, in that you can say, well, you've made this decision, I totally understand and respect that decision, but others might be surprised by it, and if we want to make sure that your wishes are respected, either after your death or at a point in time where you may lose capacity, the best thing to do is to make sure not only that it's properly documented, but that actually we get a formal assessment carried out as in a kind of insurance policy to protect your decision making, which makes it a bit easier for the advisor, and you can distance yourself from what might be perceived as a challenge to their capacity. Yes, and I think if you get a good clinician taking that up for you, they should also close the loop in terms of care. So I saw someone on Friday who, it was for a capacity assessment, but I realised that they had an agitated depression and a dementia that was undiagnosed, and so I've written to their GP just nudging them to get some care for that person, in addition to all the medical legal stuff that's going on.
The situation you've identified is the much more black and white one. I think the more difficult conversations are actually with clients with the addiction or mental health problems where it's fluctuating. So one day you may have a very sensible conversation and get all the instructions you need, and the next, and I've had this with clients with addiction problems in particular, you might get a phone call where really they're not making much sense at all, but they're asking you to action something urgently, which puts us in a very difficult position as lawyers. The last thing you want to do is take a step that day, which they may well question, challenge the next day, or confirm that was never actually the purpose of their instructions. And so that what we would normally do there is you would go back to the client, confirm in writing what you discussed on the call, and ask them to confirm their instructions in writing. Again, that's fine if you're not up against it in terms of a deadline. If you have got deadlines, you're in a very difficult position if you think that person was under the influence of alcohol or drugs and therefore not necessarily giving you their firm views.
Well, and this issue of fluctuating capacity, of course, we all know that capacity is decision and time specific. And there are a large number of mental illnesses that can fluctuate wildly. So some types of dementia, you can be very lucid at some times of day and very impaired at other times. Depression tends to be you're at your worst in the morning. So if you have an early morning assessment with the client, they may lack capacity, but in the evening they may have it. Whatever is underpinning the reason for incapacity, we've always got to bear in mind that it can fluctuate.
Which is what I think the Mental Capacity Act reflects in itself, doesn't it? In terms of the test and the fact that ultimately you're trying to give people the autonomy to make decisions for themselves, no matter how unwise they might be. And it's very much, and this is where I think perhaps some of the assessments that have been carried out, or that I have seen, are not necessarily focused enough on the time and decision in question, and perhaps take slightly too broad brush an approach when it comes to assessing that person.
So I think you can blow some holes in a lot of mental capacity assessments for both of those reasons. First of all, the Mental Capacity Act Code of Practice impels us to maximise capacity, and that's simple things like going at the right time of day, making sure the hearing aid's switched on, using pictorial images if necessary. But it's really important to do that.
I think one of my biggest concerns from the reports that we often see, both from the lawyers and the medics who've perhaps been involved with someone and assessing them and taking instructions from them during their lifetime, are that rather sweeping statements are made about their condition. So often you'll see lawyers making comments about the fact that someone has capacity. So they've clearly asked themselves the question but haven't actually challenged it. Is that something that you regard as an issue as well?
Yes. So I do a lot of retrospective capacity assessments, probably about 40 a year. And one of the most fruitful things I will often look through for clues as to whether the person has capacity is attendance notes. And the attendance notes can be absolutely fantastic and sparkling and very detailed and very helpful. And sometimes you get attendance notes where the lawyer has written, I'm sure that they've got capacity, full stop, with no reference to Banks and Goodfellow. And of course that leaves me thinking, well, I'm not assured about that. Sadly, I think that quite often this happens in clinical notes as well, and a very, very common thing. I've seen clinical notes of people who are very, very severely affected by dementia to the point that they can hardly speak. And they have encounters often with people like physiotherapists, occupational therapists, and the first thing they write in the notes is, had capacity to consent to assessment. And it's almost certainly that they didn't. And I think that there's a big trend at the moment for clinicians to write in notes that someone has capacity to insulate themselves from censure down the line. But of course, when that person's died and I'm looking at those notes 6 years later, that's a real difficulty for me.
So what is it that you would expect to see in terms of questions that they should be asking, both themselves and the patient?
Well, I think that a minimum that I need to see to be able to rely on something, an assessment of capacity, is at least a nod to the 4-stage test in the Mental Capacity Act. You know, can they understand? Can they retain? Can they weigh? And can they communicate? Now, I'm not expecting that clinicians write that every time they see a patient. Just stop writing that they have capacity, tick.
And then in terms of age, at what point does this kick in? Is it only going to be for patients or for clients where you think that there is a clear concern about capacity, or is it something that should be carried out more widely?
My view is that you don't need to do a capacity assessment for every encounter you have with a client or a patient. I think you should be doing capacity assessments properly at the times that real decisions are made, and that is what is sometimes missing.
I think so, and I think this touches back on what we said earlier, that actually capacity issues don't just affect elderly clients. And so in terms of deciding where to draw the line and mentioning it to clients who may well be in their 40s and 50s, but with no obvious signs of capacity issues, but where one knows that actually family dynamics are complicated, there may well be a challenge later on, or perhaps a wider issue that is worth meeting head on and raising and putting in the context of a capacity assessment and saying, actually, this is all part of your insurance policy.
Yes.
There may well be concerns further down the line.
The other thing I want to bring up about particularly younger people is the issue of traumatic brain injury. We get quite a few referrals for TBI, and the thing about traumatic brain injury is that you can appear to, you can certainly talk the talk And so people will, with the standard cognitive tests that people might throw at them, such as the mini mental state examination, we may talk more about that in a minute, you wouldn't pick up any difficulties. But so unless you use much more sophisticated assessments, you will miss the fact that people might have quite significant but subtle and occult cognitive impairments that would definitely impact on capacity but are not detected. And I'm particularly concerned about people with traumatic brain injury, often with large settlements, being given carte blanche for their financial management.
In terms of managing their affairs,
Yes.
or then deciding what happens
Yes.
with them.
Yes.
And I think, well, it's all part of the advisor trying to find the full story out and not just going on what they see and who might walk through the door on any given day, but actually getting to know their clients and learning to ask the right questions of them. One of the things that I thought was going to become much more commonplace 5-10 years ago was video assessments or some sort of video recording when it comes to people giving instructions in relation to their wills or in relation to big substantial gifts. But that doesn't yet seem to me to be the norm. I don't think I've ever come across one. I think you have.
Yes, I do them. And I don't quite know why they're not the norm, because for two reasons. First of all, nothing is better to play in court than a video or an audio recording. I mean, it really brings the judge into that person's room, and they can make a fairly definitive view on that, much more than whatever a professional might write in a record, in a report. But the other thing is that it insulates the professionals. I mean, I do video recordings when it's very contentious, simply because I know the other side is going to produce a report that might say something different to me, and I can say, look, here's the recording, make your own judgment.
And I think judges always love hearing from the patient or the person themselves rather than those who've met them.
Absolutely.
And anyone's notes are always going to be their own impression of them at the time, which is in itself not entirely satisfactory.
The only caveat I'd say about this is when you're doing video recordings, it's important not to lead the individual in the responses, though. But often, especially with people with dementia, you can't ask them lots of open questions either. So the questions you ask them have to be very carefully crafted, so that they're not so that they can be responded to, but they're not leading.
And again, filming may well make some people more unsettled or feel.
I've never known that.
Really?
I've never known that. Every time I've suggested, can we record this, people have said yes.
How interesting. Well, I guess also, it's, as you said, when you get to court, it's quite a powerful voice, and you get that with LPAs and the Court of Protection judges wanting to go and meet the person and speak with them, even if their capacity may be fluctuating. And retrospective
Right.
assessments themselves are fundamentally flawed because you're only relying on the
Absolutely.
medical records that you're presented with. They're never going to tell you the whole story, are they?
No. And it's I love doing retrospective assessments, but it's definitely second best. The by far and away the better thing is if there's any hint of contentious issues downstream, get an assessment done.
I think lawyers tend to regard, if they see a file and someone comes in and there's any hint of a mental capacity problem, whether it's Alzheimer's, dementia, or any form of problem, to automatically assume that the default is that someone lacked capacity, and then it's on the other side to try and prove otherwise. And I think that is still commonplace, actually, amongst lawyers. I don't know whether you feel similarly.
Yes, I think that's true. I mean, we're back to the Mental Health Act, the good old Mental Health Act, which says, don't assume that someone lacks capacity just because. And it's very clear that people with dementia can make quite complex decisions, particularly in the early stages. In fact, I did some original research that showed that there was very little correlation between scores on cognitive tests and mental capacity. This is because you might score extremely well on most aspects of a cognitive test, but have an executive dysfunction. By executive dysfunction, I mean that you're not able to process information, think abstractly, and use your judgment. These are higher mental functions that are not well tested on some of the basic cognitive tests. You only need that to go awry. You can score very highly on the cognitive test, but you're not able to make the decision.
Which leads us to talk about the MMSE. I know you have some strong opinions on it, but I also think it ties into the views of family members, doesn't it? Because I think sometimes they can see in someone's files the fact that they scored well on the MMSE, but that they know that their family member was lacking in the executive function that you've alluded
Exactly.
to. And I think that's the cause of huge frustration and perhaps why there is so much litigation out there, because I think perhaps some of the traditional medical tests that are still carried out as a matter of course don't necessarily represent what family members might regard as the person that they were living with until they died, and how we've addressed that gap when you're only dealing with historic records.
I would say that about 3/4 of, because you can get clues as to whether someone has executive dysfunction. So I had a case recently where there was no test. I mean, it would never cross my desk if there was a beautifully done neuropsychiatric test. It would be an open and shut case, and they wouldn't bother to ask me for an opinion. But I had a case where someone clearly had executive dysfunction, in my view. They were kissing their doctor and nurse, and they were very disinhibited, they were very tram-lined, they were very apathetic. All of these are key features of executive dysfunction. We successfully argued that despite the fact that they had an abbreviated mental test score of 8 out of 10, that there was significant impairment there.
And was that reflected in the medical records?
Yeah, it was beautifully documented. No one had put two and two together at the time, but
as
it was
to what it
all of
indicated.
these. But all of these sort of all of these behaviours that were raising red flags about executive problems were documented.
How interesting. And I think touching back on the point that we had talked earlier about solicitors and their files and the Banks and Goodfellow test and where solicitors are going wrong. I think that's similar, isn't it? I think it's those sort of details that are often missing from the files and that can cause so many problems.
Yes, and conversely, some solicitors keep beautiful notes. And I had, sorry to go on about real cases, but this was a case where someone had burst into the solicitor's office and demanded to tear up their will. The solicitor had interviewed that person to find the reasons and documented beautifully the fact that the person believed that their neighbour, who was the main beneficiary of the will, had been breaking into their house, breaking into their safe, stealing their papers, broadcasting scurrilous stuff on the local radio. They were psychotic. They were clearly psychotic. I'm sure that neighbour wasn't doing all that stuff. And the person, there was nothing in the medical notes about psychosis. They'd had a small stroke, and I think they got psychotic as a result of that. And the solicitor had unwittingly made the diagnosis and saved the bacon. So solicitors' notes are hugely important when they're well written.
And also, I guess, as far as medical records are concerned, there's also certain medications, because I've had a case recently where someone was scoring perfectly in terms of their underlying health problems and there weren't any perceived difficulties, but was in the sort of final stages of dying from cancer. And it was actually the retrospective assessment that showed that actually in the final stages of their life, where they seemed calm and reasoned to family members, actually they weren't necessarily in a position to express their clear and thorough and well-considered views because they were heavily sedated or at least under the influence of certain end-of-life medications, which would have had a profound effect on their ability to make those sorts of decisions and their cognitive function.
Yes, so end of life, you're often on Oromorph or something similar. Well, if you look at the British National Formula on Oromorph, more than 10% have somnolence, so it's half asleep half the time. They're often on diazepam or other benzodiazepine medication. That's going to complete. I don't know if you've ever taken 5 milligrams of diazepam, but you simply can't think straight when you've done that. So yes, I mean that's another issue. But also brings me back to the other concerns about people who are very unwell, about the medical issues, and something as simple as a constipation causing urinary retention, very common in end-of-life care and palliative care, because the drugs are making you constipated and causing those difficulties. And the drugs themselves can affect your brain function. So there's multiple different facets as to why.
And there's those sorts of details that you would pick up on a clinical file, which other people might not necessarily realise the profound impact that a combination of those different factors may well have had on that person.
Yeah. I guess the message for me, Charlotte, is that this has been a fascinating discussion. Thank you very much for that. And I think that it's reinforced my view, which is quite a long-held view, but substantially reinforced, that the best way forward is for lawyers and clinicians to work hand in hand, and I think that means you sending the clinician a properly constructed letter of instruction, which is very detailed about what is the question and what is the background. Then the clinician doing the right tests, both in terms of mental health tests and cognitive tests, but also the right capacity test, and then sharing your thoughts on the construct of the report. Now, obviously, I'm not going to change my opinion based on your feedback from the report, but you're the lawyer, you can advise me about the crafting of the legal aspects of it. And I think that working jointly and ideally seeing the client together, I think that's ironclad if there's the lawyer and the doctor in the same room at the same time.
I think so, because I think it puts into context, doesn't it, the questions that are being put to the clinician about the specific decision that's being made. And I think touching on the point that you've made about the sort of take-home points from this discussion and from more general experience, it is that I think as a lawyer it's very easy to fall into that common trap of someone's come in to see me about a will, it all seems very sensible. They seem on the surface entirely sensible. But without scratching the surface, I think it's very hard for that lawyer to be able to say hand on heart in their notes of that discussion that there are no concerns as to capacity without having really spent some time getting to know that client, getting to know the context for their discussions, and also trying to get a better understanding of them and their family. And as you said earlier, in terms of there might have been a traumatic brain injury in the past, which may well be affecting what's going on in that discussion. And it's all about getting to know your client and their other advisors, whether they're clinicians or other financial advisors and accountants, and really making sure that you've got the full picture in which to be able to put the specific decision that you're considering at that moment in time. James, thank you very much for coming into our offices. I know you've been seeing patients today, but it's very nice to have been able to speak about these issues in person.
It's been an absolute pleasure, and thank you for inviting me to such a beautiful office. Really wonderful, thank you.